Hiyo kijana mwenye umetuma kwa nani? Kwenye
to welcome all of us into our webinar. So I want to request a volunteer to lead us in a word of prayer. Any volunteer can unmute and pray for us, please.
Let us pray.
Diana, you can pray for, or Lucy, you can go ahead.
Dear Lord, we come before you this afternoon, full of thanksgiving in our heart. Thank you for the opportunity you've given us to do.
Lucy, you are unmuted.
You
You can pray for us. Lucy Wanjiku.
Yeah, we are praying. Dear Lord, we come before you this afternoon. We give you thanks and we give you honor. Thank you for the opportunity you've given us to meet, oh Lord. We invite you to be with us as we start this meeting in the middle and even as we come to an end. We
So,
dedicate
Ellen Masiva, can you pray for us?
Okay, thank you. Let's pray. Almighty Father, we come before you this afternoon. We thank you for the gift of life. As we start over this meeting, may you guide us. As you see the end of the meeting, thanks and praise shall be unto you. And in the name of the Father, the Son, and the Holy Spirit, I pray and believe. Amen.
Amen.
Okay. Can someone confirm if you can hear me? I don't know what's up with my mic.
Yes, you are.
Am I audible?
Yes, you are.
Can somebody confirm if you can hear me?
Sumbuk, you are loud and clear. I don't know if your audio is wrong or is something wrong with your audio.
Okay, Otero, confirm you can hear me.
There is a lot of crosstalk on your end.
Projector.
Songo, can you hear me? Thanks, Beatrice, for confirming that. Looks like the limit that we have for this link is 500, and we were expecting more people. We're trying to see if we can move other people to YouTube. If you know anyone who is locked out, we'll be sharing the link that we've mirrored this so that they don't miss out. Songok? Songok, can you hear me?
Recording stopped.
Hear me? Someone just confirm they can hear me. Confirmed. Oh yeah, I can see on chat you can hear me. So we are trying to see if we can get another link. The NASCOP team are having a challenge joining, and I think we have reached a maximum of 500, and we expect many people on the call. So kindly bear with us as we look for alternatives. Just give us a few minutes. Thanks.
However, we are also planning to roll out the trainings, either physical or online, for the orientation with this EMR tools. I think I don't have much to say apart from welcoming my fellow colleagues on board. Really?
Thank you, Robert. I think in the spirit of embracing technology, we have been working with the directorates of digital health and health informatics, because we are also progressing to the facility-wide digitization. And so as we align to that agenda of digitization, gosh, I've been logged out again. So at this point in time, allow me to request Dr. Wamishwe to make her remarks, and then also to invite Dr. Manya, who's the head of directory. Then we shall proceed to have some remarks from NASCOP, and then we move to the next agenda. Dr. Wamishwe?
Yeah, so good afternoon, and thanks, Lily, for inviting us to this meeting. It's nice to hear that the counties are well represented, and also nice to see the partners that we work with are also in this meeting. Lily, am I supposed to say what I'm supposed to say right now regarding digitalization?
Yes, please, Dr.
Okay, so I know today we are here to talk about the
I find
HIV,
the word digitalization
tools,
weird.
how they have been incorporated within KenyaEMR, so that we can start seeing data flowing as
She's
regards
currently the head of
few
HMIS,
variables that perhaps have been added.
but also the CEO
But I also wanted to bring in the whole idea that going forward, we are now pushing for the agenda of facility-wide digitalization. So what does that mean? Going forward,
Nimepotea bwana. Hata huyu ni venye aje.
Songok, we have lost Dr. Joyce. Please unmute the strategic information so that we can hear. Songok, someone muted. Kezia, confirm you can hear me?
I can hear you, Diana.
Yeah, someone muted the strategic information. That's what, and we could hear the presentation. Songo, can you hear us?
I was waiting for Dr. Manya. I will also request that you abbreviate your Sasa Rose amepotea.
So can I share the slides? Ako, Rose ako.
Lakini ni kama hasikia ama?
Most likely.
Rose Ngweni, can you?
Dr. Lydia, I can hear you.
Project.
Are you able to hear me, Songo?
You see? So I can.
Kuna mtu anaona? Katika screen kasi. Kazi kama niendelee.
You.
Franklin, we can hear you. Can you hear me?
Yes, Rose, you're very clear.
Yeah, I think the two systems are not coordinating well. So when we can hear them, they can't hear us. When they can hear us, we can't hear them.
Rose, can you hear me?
Yes, Franklin, I can hear you. Can you hear me? Diana, I don't know.
Rose,
maybe you try and yes.
you are very clear. The problem with the Songok, he's muting. We can hear when he unmutes. When he unmutes strategic information, the host we can hear, but when he mutes, we can't. We can hear you clearly.
Yeah, I think we are both on the same platform, me and you.
Yes.
We're about 500. We can hear ourselves.
Yes.
Then they can hear themselves. Those who are.
So maybe you can just project and proceed.
Hi, Rose. Hi, everyone. You can hear me?
Yes, we can.
Okay, let me. I think you can proceed, Rose.
Okay, because it was Franklin who was projecting, but do
you have the presentation? You can go on the presentation.
Oh, okay. Let me do so.
Yeah, as we sort ourselves decide.
Yeah, I think we are both on the same platform, me and you. Yes, 500. We can hear
Are you able to see my screen?
They can hear themselves. Those were.
So maybe you can just project and proceed.
Hi, Rose. Hi, everyone.
Are you able to see my
Yes,
screen?
we can.
Not yet, Rose. Let me. I think you can proceed, Rose.
Okay, because it was Franklin who was projecting, but let we.
Do you have the presentation? You can go on the presentation.
Oh, okay.
Diana, can you see my screen?
As we sort ourselves decide.
Yeah, I think we are both on the same platform, me and you. Yes. We can hear what you say. They can hear themselves. Those were.
So, Rose, kindly project. Yes, you're now projecting. Put in the presentation mode.
Okay, okay, I think I have it.
Yes, you're now there. Okay, proceed.
Okay, thank you. And good afternoon, everyone. We really do apologize for the mishap, but I believe we can be able to proceed and it will end well. I'll be presenting the overview of the tools revision process. There are about 3 slides, and then we'll usher in back Dr. Lily. So I just wanted to briefly state that our journey to the revision of monitoring and evaluation tools for the HIV program started way back in 2020. And this has been running in tandem with the revision of the HIV guidelines, specifically the prevention, care, and treatment guidelines. So this has really allowed us to incorporate any new developments, including the latest revision in the prevention guideline on the 3-test algorithm. So the revision of the national and global documents actually necessitated the revision of the M&E tools. So we were not reviewing M&E tools in a vacuum, but in line with the national and global guidelines. In this process, we were able to identify and remove redundant indicators that are elements that were not in use due to, or that were not going to be in use due to the revised guidelines. The intention of the review was equally to reduce the burden of data collection and reporting on health providers, and to just make the data collection tools as lean as possible, and also to allow the healthcare providers to really focus on their core role, which is the provision of services to the client. Part of the objective of the revision was to eventually build capacity of our healthcare providers at all levels to utilize the revised tools to generate quality data for decision making. In the process of reviewing the national and global strategic documents, we realized that we had new terminologies, new definitions of concepts, and even indicators. So this process actually allowed us to harmonize and foster a common understanding of the new definitions, key terminologies, concept, indicator, variables, and data elements. For example, for test and treat, and also what I previously mentioned, the new the 3-test algorithm. Basically, some of the principles that we really focused on, as I've mentioned, was to reduce the burden of data collection and reporting for health workers. And we also wanted to understand the guidelines, and of course, at all levels, understand the guidelines in line with the monitoring and evaluation. We also applied the principle of the result framework, which focuses on the goals, objectives, and expected deliverables. And this really guided the revision of especially the reporting tools, and then which also guided the review of the reportable indicators. So what we did is that for reporting purposes, we managed to focus on outputs instead of processes. And we had to make sure that processes were to be monitored at facility level by the service providers, and could also be used for service quality assessment. So for reporting purposes, we mainly agreed that we were going to focus on outputs rather than reporting processes. So processes monitoring were to remain and be at the facility for service provision, and also to aid the supervisors to monitor quality of services at the facility level. Just a mention on something on a transition. All data collection and reporting tools, including platforms, have been revised and are ready for use. That includes the training manuals, the actual tools for data collection and reportings, EMRs, the KHIS, e-learning platform, and even DQA. All these have been revised and are ready for use as we speak. Training on manual tools were actually have been conducted, and this was done last year around October, November, and we managed to upload all the data collection and reporting tools, including the PowerPoint presentations, the training manuals, into the NASCOP website. Even now, if you open the NASCOP website, you will be able to access all the revised tools, including the training materials. So this was to aid in ease of access for the training materials, and also printing at facility, at sub-county, county, or even at national level. As opposed to previously when you had to write an email. So we just thought it was wise to have the tools uploaded and accessible to all at any one given time. The EMRs, I think, which is the reason why we are here, will be taken through how to utilize and navigate through the revised EMR platform. We agreed that we focus mainly on customizing the clinical encounters for all services for use of data collection in the EMRs, and of course, for purposes of reporting, this was to be an automated report. We were supposed to have automated report generated from the EMRs, and that is what have been done, and we'll be able to see that. Now we have the national printed tools, and we are looking forward to distribute from possibly next week. And the printed tools will only be available and be distributed to non-EMR facilities. And we expect EMR facilities to actually use the soft copies of the developed tools. And that is the reason why we are here. So we are looking looking forward to deactivate the old tools from KHIS, and that will be in January 2025. So we are giving a leeway of around 6 months so that all facilities, sub-counties, counties are able to prepare themselves by training and just making sure that they have the new tools available at the service delivery points, so that in the next 6 months, we will all be able to have the new tools at the point of service delivery and be able to report to KHIS. So as at January 2025, we will be looking forward to deactivating the old tools in KHIS. And we believe by that time, every service delivery point will be ready for the transition. So I think that brings me to the end of my presentation, and I will usher in Dr. Lily to be able to present for us what the call to action is for these new platforms. So Songok, if you can hear me, or Dr. Lily, I give you back the mic. Thank you.
Yeah, thanks, Ross. I'm using Elvis' machine. Can you hear me?
Yes, I can hear you, Franklin.
All right. I don't know that Dr. Lily can hear us. Sorry, my sincere apologies. I think we have a lot of issues with technology. Okay. All right, so I think we can proceed. Rose, you can stop sharing your screen, and I want to welcome the Palladium team. That should be Mary Ann, to take us through the next presentation. We'll go through the KenyaEMR introductory slides and the introduction of the new tools. So this session will be co-presented by Mary Ann and Eugene from Health IT. Mary Ann, if you can hear me, you can take over. So Mary Ann, let me unmute you. Mary Ann, can you raise your hand? So
Good afternoon. Sambok, confirm I'm audible.
Yes, we can hear you. Please proceed.
Thank you. Good afternoon, everyone. My name is Miriam Monti. I work with Palladium. Let me take you on a brief journey of KenyaEMR 3.x. I may use the term KenyaEMR 3.x, KenyaEMR 3.0, and the system interchangeably. Please note they mean the same thing. Next. So KenyaEMR was developed in 2012 as a distribution of open source medical record system. And its design approach is scalable, and it was developed for the user with the user. The system was primarily adopted by MOH health facilities, primarily for the HIV program. But last year, it was upgraded to the new OpenMRS 3.0 platform that offers additional functionalities beyond the HIV program. KenyaEMR 3.x has been developed for sustainability. It has a very lightweight user interface that supports clinical decision support, integration with universal health coverage, and primary care networks. The system also supports tracking the last mile of a patient journey through a robust finance management and billing module and a commodities and dispensing module. Next. So KenyaEMR has several features. One, access to KenyaEMR is based on an individual user responsibilities, where login credentials are attached to specific user roles and system functionalities, thus allowing the system to limit a user from accessing unauthorized information. It also supports direct access to specific departmental modules and functionalities using selected location at login. It supports automated clinical workflows that are integrated in the clinical forms with the support of an interactive system that provides feedback after an action is complete in the system, such that when a clinician successfully saves a form, the system will give a successful message for that kind of an action. The system is integrated with intelligent alerts and machine learning prediction that supports specific precision programming in key programs. It has also streamlined facility processes. That way it is able to simulate end-to-end of a patient journey in a facility setup. It also has provision of granular level data that is able now to support greater control of the system output, to support more efficient analysis, and it can also support decision-making and strategic programmatic interventions at a facility level. It has also been subscribed to the shared health records, client registry, the Kenya naming health terminologies, and the Kenya medical health facility lists, meaning it has it's part of the digital superhighway integration. Next. So let us briefly look at some of the key functionalities that KenyaEMR now has to offer through now the hospital-wide solution. So KenyaEMR has specific standardized services, starting with key services that are offered in each service area that can be centralized so that we can be able to eliminate duplication and provide efficient and a more positive patient experience. One of them is universal client registration, efficient patient flow management using queue service functionalities, and a robust centralized appointment management for all clinics. Then we have inclusion of management forms for special clinics, just to mention a few. We have HIV and TB clinics as special clinics whose workflow is integrated into the system, physiotherapy, eye, dental, renal clinics, and even MOPC and DOPC clinics. As well, we have diagnostic testing support for clinical procedures, for radiology, for laboratory requests that have well-defined workflows that support user processes at each service point. It also has a robust revenue collection and stock management module to support billing and commodities operations, as well as now it also offers the functionality of administrative support using well-defined system access roles, availability of MOH registers and reports, as well as visualization of customizable dashboards that can now be able to address the needs of different levels at the facility, county, sub-county, and even at the national level. So some of these dashboards next are an output that can even be given at facility level, whereby the facilities are able to access data generated from the system. They can be able to create, customize, and generate dashboards that are able to display aggregated OPD inpatient data in terms of workload. They can also be visualized by department workload and even distribution trends over time, as displayed on this particular example of one of the dashboards outputs we have in KenyaEMR. And at facility level, this will be useful to help monitor, one, the burden of disease by disease type, by notifiable case, and so on, as well as provide efficient and effective use of healthcare services by being able to visualize average client waiting time per department and even by service provider. Next. At the county level, we also have powerful dashboards that even at the county leadership, you can be able to get a powerful drill down capability of a near real-time visual summary of statistics. And this can be drilled down per sub-county and per facility. And it allows the management at the county level to be able to monitor for specific inventory status, revenue collection, notifiable cases, top 10 diseases, trends over time. And the good thing is that both dashboards allow or give the capability of customization. And this customization can be specific to the needs of a facility, as a county, or even a county. Next. So over time, we have had changes, or what we are calling transition to KenyaEMR 3.x, more so migration changes from 2.x to 3.x, whereby all the HIV modules that were primarily in 2.x have been migrated to 3.x, with only the reporting module that is currently being migrated by the Palladium team. And this is to support now both HIV and non-HIV services in KenyaEMR as part of the integrated patient-centered approach. So the HIV modules have been integrated to the clinical workflows among the special clinics in 3.x. And we can even see from the diagram here, even the UI or the patient homepage looks a bit different. It feels different, where we have now some of the modules that we had in 2.x versus what we have displayed for 3.x, where we can be able to see that for KenyaEMR 3.x, next, even the patient profile looks and feels a bit different from what we had in 2.x. In 3.x, it gives more functionalities even to the clinical team who are seeing the patients. It allows them to have an interactive patient-centered profile where they can be able to access the patient summary, historical data, current data for the patient that for that particular visit. As well, they can be able to access all applicable forms for that particular patient, depending on the programs they have been enrolled to. So the feel and look is a bit improved and allows for multiple interactions, and it's a bit more dynamic. Next. So KenyaEMR has had some enhancements to support facility-wide EMR with the inclusion of revised NASCOP HIV and M&E tools that have been incorporated in several tools, for example, in PHQ9, KenyaEMR, as well as the IIT package of care that is defined in the HIV treatment guide of 2022. We also have inclusion of the revised comprehensive MOH 731. And as well, for automatic indicator reporting, it has been enhanced to reflect the revised HMIS datasets and indicator mapping as well. On the side of facility-wide modules that have been enhanced, we have the inclusion of a fully fledged OPD module, a medically assisted therapy module, as well as now the ability to have billing and payment processing of specific billable services within KenyaEMR, as well as a comprehensive stock management module, a dispensing module that also is supported by the community pharmacy module, as well as now the availability of specialized clinic workflows that also includes non-communicable diseases management. We have an integrated prescription orders, integrated laboratory, radiology, and procedures orders in the clinical workflows. And additionally, we also have now availed all the necessary reports and registers from this additional modules and additional services. Just to mention a few: inclusion of MOH 734, MOH 240, MOH 717, MOH 705A and B. Next. So the KenyaEMR 3.x deployment has been a journey on its own, and it has been quite a progressive experience, where we started with the national and county engagements. At this point, 21 counties were directly engaged. This was followed by county sensitizations that happened in all the 47 counties, whereby 190 county personnel and 43 service delivery partner personnel were engaged. And this engagement now led to specific TOTs being given from the counties and from their service delivery partners, whereby now a training for the TOTs was done on KenyaEMR that reached 131 county TOTs trained, and 48 partner TOTs were also trained from 40 counties. Controlled deployment for KenyaEMR 3.x was also supported in several facilities across the country, with 75 facilities being upgraded for HIV use case, and currently 53 health facilities have started to implement and use facility-wide implementation for KenyaEMR 3.x. Currently, scale-up is ongoing, where upgrade from 2.x to 3.x in the HIV clinics is being led by the partner. For facility-wide use, this is being led by the county and the partner as well, while the trainings and capacity building efforts for the TOTs have been led by the HIS partners, Palladium and Health IT. So currently, all service delivery and county partners have been trained to deploy the 3.x independently. They can be able to do this on their own. And partners and county TOTs are being encouraged to offer first level of technical assistance to facility-wide deployments that are ongoing. And to notice that KenyaEMR 2.x has finally reached the end of its life support, and we need to pull the plug now. To continue with the next slides, I would like to invite my colleague Eugene to take over. Thank you.
Yes, good afternoon, everyone. Could you confirm if you can hear me, Songkok?
Yes, we can hear you and we can see. Please proceed, Eugene.
Thank you very much. I'm Eugene Murunga from IT, and I will be diving through in a few numbers that Marianne has presented. So as you can see, KenyaEMR 3.x deployment stroke scale up, we have had counties, and as we stand currently now, we are having 75 facilities where we appreciate the initiative of the various partners across the various counties who have actually enabled the 75 facilities to be able to move from 2x to 3x in the HIV spectrum. So we have Kisumu County leading with 11 facilities so far, which they have actually managed to move on their own with their partners. And you can be able to see we have Siaya County, Nairobi, Homa Bay, Mombasa, Nyeri, Meru, Embu, Trans Nzoia, Makueni, Machakos, Bomet, Kericho, Kitui, Laikipia, Vihiga, Kiambu. We'll be able to encourage partners to be able to take up and be able to follow up this. On the other side, we have facilities like around a total of 53 facilities, which have actually been able to move to 3X, and they are using the system both for HIV and non-HIV. And the facilities, as we speak, are in Kisumu counties, Mombasa County, Homa Bay, Embu, Vihiga, Meru, Kisii, Kakamega, Nairobi, Nyeri, Siaya, Taita Taveta, Bungoma, Nyamira, Trans Nzoia, Elgeyo Marakwet, Kajiado, Kitui, Turkana, Laikipia, Bomet, Machakos, and West Pokot. So the process is still ongoing, and we are hoping and anticipating that the number will increase. Because you can be able to see we are having 2,273 facilities which are currently using KenyaEMR 2.x on the HIV side. And we are having a plan of a target of 477 facilities in phase 1 by September 2024 to have upgraded to the general facility-wide software. Yeah, so that's just a follow-up on the conversation and the engagement that the county led, and they came up with these particular numbers. Next slide. So in this particular process, we have, I can't say it has been a walk in the park, but we have really tried our level best as the national HIS partners and all the service delivery partners on the ground. So in the process, we have encountered various challenges, and we have been able to put up various mitigation measures. And one or two or three of the challenges we have been able to get is that's just general challenges. We had infrastructure challenges and partner support. So in general challenges, we had limited support for 3X deployment in ASAL counties due to the funding scope. Another challenge, we had the existing systems and the ongoing plans for alternative. These are just the private proprietary softwares that are currently in some of the counties or in some of the facilities in the various counties. And that was one of a bit challenge, which the counties needed to be able to agree on the preferences according to their plans. The second challenge, we had infrastructure issues. We will realize that various facilities have inadequate workstations, limited network coverages. We have the infrastructure that they're having, the computers or the gadgets for point of care have low capacity for 3X deployment. And then the last issue that we were able to note was partner support. We had limited funding commitment for facility-wide implementation for the support from the partners because we understand that their support was majorly anchored on the HIV side. And there was another problem of insufficient budget for additional data bundles, demand for facility-wide implementation for the facilities that are currently operating on cloud-based EMR. There were various mitigation measures which we were able to employ and bring up to speed. And one, we had increased as a sustained advocacy and change management initiative at county level. We had these discussions at the various CHMT level to be able to find an amicable solution or a win-win solution for everyone. Number two, we had to seek partners to county support to procure additional services and to procure additional devices, and extend network coverages to the required service points, and also allocate resources for replacing or increasing EMR servers terminal to address performance challenges. On partner support, USG guidance on the role of stakeholders in facility-wide EMR rollout came in handy, and with clear objective review of data bundle consumption also came in handy for the facilities that are actually on cloud based EMR. Next slide. Next slide. So in the process, we have had various feedback from various stakeholders at the various counties. And one of the feedback that we were able to get after the first version of KenyaEMR 3.x deployment, we had an issue of TX card drop for some facilities, limited SDP support for facility-wide KenyaEMR 3.x rollout, and increased data bundles demand for cloud-based deployment. We had these issues were anchored on various causes, and one for TX card, this was due to migration to a centralized unified appointment management module that decoupled a recording of appointment from the clinical form. That's the green card, which we normally use. And this affected facilities using a retrospective data entry appointment. We were able to take action, and we were just able to enhance the appointment form in KenyaEMR to indicate the date on the date on an appointment that was issued, and capacity building on the change appointment managed flow was enhanced, and this was able to sort out the issue of the TX card drop on the facilities that encountered that particular problem. On limited SDP support for facility-wide KenyaEMR 3.x rollout, we have had a planned weekly virtual training series where partners are encouraged to attend, and also on-site visit. When we are doing deployment, we engage and incorporate inclusively both the county and all the service delivery partners to participate in that particular process of migrating from 2x to 3x. On increased data bundle demand for cloud-based deployment, we have had various measures where we have tightened role-based access, adopted the various technologies under rollout to be able to mitigate the high consumption of data bundle for the cloud-based EMR. With that, I would like to welcome Kezia to take over from there.
Good afternoon. Confirm if you can hear me.
Yes, we can hear you.
All right, thank you. I'll be taking us through the revised changes on the tools. We can go to the next slide. So we will start with just the facility workflow. Right from the HTS, a number of changes have been effected on the HIV testing services, one of them being the population types. We are used to having 3 population types, the general, key pop, and priority, but now the key and the priority have been combined to make it one that is key and vulnerable populations. So as you get the new tools, now you'll have general and key and vulnerable populations, and that has already been effected. Again, we have a new testing algorithm. I think this was mentioned. So since we are aware that the tools may not be available at the moment in your facilities, with the first version of KenyaEMR, you will have a combined the old algorithm and the new one. So you'll have a set of all the tools, all the test kits combined. So the validation has been done to accommodate the two algorithms. So depending on the kit that you select, it will determine which algorithm you're using. So that again will be now for the first version, but once the algorithm is fully rolled out, we'll be able to enhance the EMR to capture just the new algorithm. Having talked about that, it means the 3-tier testing algorithm is also incorporated in the tools. And these changes will affect all the forms where testing is done, starting from HTS eligibility screening form, the HTS initial form, retest form, all the MCH forms, that is the ANC delivery, and the PNC form. So you expect with the revised tools, you'll see these changes. Next. Moving on to HIV program, there are changes that have happened on the various tools that we use. Starting with HIV enrollment, we had different options on which client would previously have used ART. On these, HART and PMTCT has been dropped as an option for previously on ART, since we are currently using a test and treat. Then we have HBV, which has been introduced as part of ART that client may have used previously. On the same tool, we have an additional test as part of the baseline assessment. That is the estimated glomerular filtration rate test. Under the green card, again, we have a few changes there. Key population, just like I mentioned, this will cut all the form across all the forms, where we now have key and vulnerable population in place of the key pop and priority. So the two have been merged. Then we have under the PHDP section on this tool, we have added cervical cancer treatment as per the guidance. And then on the differentiated care model, now we have two broad categories. It's either facility distribution or community distribution. And now they are the specific models under each. So based on the client you're attending to, you'll be able to specify the specific DCM model. Other tools that have been updated to capture the revised guidelines is PHQ9 to include the psychological first aid assessment. So based on the category or the screening category on PHQ9, then the client will have additional variables for that. We have also aligned KJ and CRAFT for the respective age groups. I know this has been a gap for a while, but we've managed to work on it. And then on the triage form, there are changes to include the nutritional interventions. So those are the changes on the HIV program. Next. Moving on to MCH program, we have a number of changes again under the antenatal form. And these may not be very major. So we have, like on the breast exam, we have options changed to normal and abnormal. I know previously we were looking at yes or no. We have not applicable added as an option in the deworming variable. We have HIV preventive services added as an option for referral, and reason for referral has been added. As mentioned earlier, the 3-tier testing has been added. On delivery form, we have the testing algorithm incorporated. We have other as an option for uterotonic given also added. And then we have added birth with deformity options. So previously we were just looking at yes or no if there is any deformity, but now we have congenital syphilis, spina bifida, cephalus, TALIPS added as options. For partner involvement, we have partner tested for HIV. Just as sorry about that. So Also, we have HIV preventive services added as an option in the referral section. So those are the changes on the delivery form. Looking at the postnatal, again, testing has been incorporated, the new algorithm. And then for the visit timing for both the mother and the baby, the timings have been adjusted to read 0 to 48, 3 days to 6 weeks, and then more than 6 weeks. So those are the visit timing for the visits. And then we have added vesicovaginal reflux as an option in fistula screening section, and TPT as an option in TB screening section also has been added. We've replaced presumed with suspected as a cervical cancer as part of the results within that. And then a referral reason has been added on this form. Next. Looking at the child, we have a CWC follow-up form. And on this, the major changes on infant feeding, where we have EBF, that is exclusive breastfeeding for less than 6 months, infant breastfeeding above 6 months, and those not breastfeeding as the options now for infants. And then there is a variable on immunization status that has been added on this form. For the discontinuation of children, we have added a discharge to CCC as a reason for discontinuation. We have adjusted or changed the discharge status at 18 months as a discontinuation reason to discharged negative at 24 months. Then we've dropped one option, that is a discontinuation, completed as a discontinuation reason. So that covers the changes that we've done on both MCH mother and MCH child. Next. Next program that has a number of changes, again, is the Key and Vulnerable program. And note the name that has changed from key population to key and vulnerable population. So starting with the first form that is used on this program area, we have contact form enhancements. And the first thing is that the note that I've made change from key pop to key and vulnerable population. On this form, a number of variables have been added. So as you interact with the form, you will note that we have new variables that have been introduced, and mainly on the Fisher fork. Question on fish business, the client conducts, the name of the beach or landing site. And then for the prisoners, there is the typologies for the various, for clients who are prisoners. So checking if they're inmate, their staff, or the community. Then for the trackers and fishing, there is a question on the same added. For the prisoners, there is a question on their sentence, how long it is. And then a question on NO6 has been introduced. Some of the variables that have been dropped on this is where we were checking the average acts per week, and NO6 acts per week again has been dropped. Next. We are continuing with KVP. So on clinical enrollment, we have added the additional questions or variables were introduced, and the same has been effected. So looking at the truck drivers, so we are looking at how long they transit, and also how long they have been working as either a tracker or a fisher folk. Variables that have been dropped on this form are mainly on the viral load test done, the VR results, body contact information, the body name, the body mobile number. So we have areas where program are sharing. We will find that some of these things have been dropped, so that if it is care and treatment, everything for a KVP that is captured in a different program area, then we shall use information collected on that other program. Next. The other changes, we will find them under the clinical encounter form. And I believe we are familiar with the KP program so that you know when which form is used. That's why I'm not going into those details. So the clinical encounter, the first thing that to note is that this is what we were previously calling KP clinic visit form. So this has been renamed to KVP clinical encounter form. So the changes that I'm speaking to are on this form, and we know this is usually like the encounter form for each and every visit of a KVP. So this has been revised. It has most of the changes that have happened are on this form. So on the list that is here, this is only what will be monitored or updated each and every visit when the client comes to the facility. So the bullets are the service areas which the clinician will need to fill in for each and every client once they come to the facility. And on the right, we have what has been dropped. So as part of the revisions, some areas have been dropped from that form, one of them being the HIV testing services, whereby the self-reporting part has been dropped, the counseling and all that. Also the care and treatment part has been dropped, and the intention is to use the care and treatment program information for the KVPs. Again, another area that was dropped is the post-abortive care. Next. On the opioid overdose encounter form.
Recording in progress.
One thing to note is previously we had two forms that were capturing data on overdose. We had peer worker overdose and we had the healthcare worker led. But now we have, that has been combined to opioid overdose encounter form. So all this has been added, the home, the massage parlor, the name of suspected opioid, recovered and died as an outcome, and changed referral facility to be a standalone and not an option in the outcome. So that is the overdose form that will be used henceforth. Then we have the peer educate outreach calendar enhancement. And on this, we have health education section added with options on TB, UTU, stigma reduction, disclosure, and information on NCDs as an option. Then for the prisoners, we need to know the location for these people, the wards, the cells, the block names or numbers for the prisoners. Next. Apart from the data collection tools, we have the reporting tools, again, which have been affected by the changes. So under the revised reports, we have MOH 731 summary, which has been already worked on. And we now have MOH 731 for VP, that is for the vulnerable population, and also an MOH 731 for the key population. So those are two separate 731 tools, and these have been built in the EMR. Then we have the registers. We've looked at the various programs that have been enhanced or updated, and we expect the same changes to reflect in our outputs. So ANC register, delivery, postnatal, HEI, default tracing register, HTS lab, referral and linkage, KVP activity register, what we previously knew as cohort register. We have new report or new register on KVP and HIV tracker offsite register. We have peer tracking register and outreach worker summaries sheet. So these have been revised and the changes are already available in the EMR. Once we have these released, you should be able to access it. So we have a session where we'll see the exact changes on the EMR, But for now, I think I'll hand over to Songok for the next part. Thank you.
Thank you so much, Kezia and Eugene, for that. Quite some insights, and I want to believe I've been reading through some of the comments in the chats. I see quite some excitement around the alignment in the new tools. But I am also seeing a few comments here and there around a need maybe for a more in-depth interaction for the healthcare workers to be able to actually see how these new changes look in the EMR itself. I've also seen quite some remarks or some requests for a physical meeting, and that is something that we can really discuss. I want to believe just like the many other IT systems that we use, I like to use WhatsApp. It's my best, my favorite app. So I keep reminding myself that I woke up one day and I just keep seeing updates, and I'm able to, as much as I use the app, I'm able to learn some of the tricks with the app without necessarily going through some form of a training. So with that, I feel like we probably just need to psych ourselves up to start using the system, and then we start to learn. And of course, as we use, then we are able to adapt and get to understand some of these changes and enhancements that have been put in the system. So allow me to, before we go to the demo, which I believe will also be able to shed some more light to the changes that have been described, allow me to just quickly share with you one slide on what I think is how we need to proceed going forward. So we have the CHMTs that are supported by implementing partners in most of the facilities. I do recognize that when Eugene was making his presentation, he did highlight that there is going to be, of course, a gap within especially the ASAL counties. But as a HIV program at national level, we are still working very closely with Global Fund to see how to close that gap. Nonetheless, for the sites that have implementing partners, we are asking that the CHMTs, together with the implementing partners, plan to upgrade all the HIV clinics to the new version. This new version will be out on Wednesday. 16th is Wednesday, Thursday. On Friday this week, which is the 16th of August. So the former system, which is 2.2.x, has reached its end of life support, and so no more enhancements will be realized in that system, and we are therefore encouraging everybody to migrate and upgrade to the new system, so that then we can be able to access the new tools. So the new M&D tools are currently being printed. We shall be starting to have them distributed from next week, and this will actually be done through KEMSA, and they will only be distributed to only non-EMR sites. So if you're an EMR site, you will not be receiving any physical registers from the national program. So once you have received the new printed registers, together with, of course, the upgrade for the EMR sites, we start then in the first day of September to start to utilize the new registers and, of course, the new EMR for the EMR sites. And we are expecting then to start seeing the first reports using the new revised tools from October, which will basically be the first reports for the period September, because October will be reporting for September. Yeah, so that is really what we are encouraging you to do, and we are taking some of the comments that have coming in the chat, and we shall be able to address them as we come towards the end. Allow me to request Dr. Wamishe, before we go to the demo, she had one slide, and I also recognize that there is quite a number of people that indicated that they didn't hear what Dr. Wamishe had said, and representing the directorate and also a larger call to action for the digitization agenda in the country, we would want to listen in for a minute, and then we proceed to the demo. Dr. Wamishwe, if you can hear me, kindly proceed.
Okay, so thank you for that. Sorry, I needed someone to unmute me, but I hope you can hear me. I just want someone to say yes, they can hear me.
Yes,
Hello?
Dr. We can hear you. We can hear you very well.
Okay. Well, anyway, so so I just want to repeat what I had said earlier and just show one slide. So one is we thank you for the invitation. We take note that we have the counties represented here, which is a very good thing. And then we also have the implementing partners that we have traditionally worked with for the longest time in doing a lot of this deployment. And I think we should be really proud of ourselves, all of us in this call, to be what is now currently termed as the early adopters of digital health. So in terms of what the vision we have for digital health at the ministry is that going forward, we are really discouraging siloed or what we call corner-like deployments. So currently we have those in terms of KenyaEMR is in HIV program, it's in a corner in about 2,200 facilities. In that same facility, you may also find SPICE, which is handling NCDs. In that same facility, you may also find another totally point of care solution for billing. So we are trying to encourage not trying, that's the vision, that's where we are heading to, end-to-end digitization of within health facilities. So that even if the facility has a morgue, we expect to meet a point of care solution there. It has happened, it is demonstrable in so many facilities, and that is the way to go. So even as we now talk about deployments, trainings, because of KenyaEMR 3.0, I want us to really see how we can stretch the dollar, stretch the shilling, so that if something is like healthcare worker training, we are not quite limiting it to those who are currently in the HIV service related service delivery points, but we are looking at the health facility as a whole. Because come December, we expect facilities, like the ones that have KenyaEMR, 2,200 facilities, to be fully digitized. Meaning the end user devices, we will have figured out where to get them, either from county or national. The healthcare workers will have been sensitized, will have been trained, and we be a lot of change management happening. We expect such facilities to have a bit, less resistance to digitization compared to totally virgin health facilities, and then a lot of support, because that is how we are looking at going forward. So allow me to just share the one slide I was talking about. So in terms of counties, we are looking forward, and when I say counties is the county health department, but also the police that support the counties. These are key things that we are hoping the counties will pick up on. So
collaborate with MOH to establish health facility digitization readiness and implement the same. So we are working on even a tool that's going to go beyond what we collected in the health facility census that was conducted last year. And in that tool, we will be doing the whole facility readiness to assess what does Kathonzweni, for example, require to be able to be said to be fully digitized. Then digital literacy starting from Wanjiko. Going forward, we're going to start seeing a lot of developments like having a patient portal. For example, we want Wanjiko to be able to get their health data on phone, for example. Wanjiko needs to know how to protect their health data. Hiyo simu ikichukuliwa, somebody cannot just get into their patient portal and access their health record, for example. And of course, all the way up to the policymakers at the county level. Then to confirm certification status of digital health solutions within the counties. So this is something that's going to start happening soon. The Digital Health Agency that's been established under the Digital Health Act will be the one doing the certification of all digital health solutions, just to make sure that we know who is behind these digital health solutions, but more important is to ensure that these digital health solutions can access the health information exchange. Then thirdly is facilitate onboarding of respective health facility digital health solutions into the HIE. I've mentioned that. But for you to join the HIE, you need to have a point of care solution and not a siloed, not a corner one, end to end. And then to collaborate in updating selected registries, like, for example, the Master Facility Registry. So traditionally, we've used the Master Facility List, but now we want to have it as a registry that collects additional information and data on the health facilities, number of ICU beds. We don't want to go back to how we were doing it during COVID when we were using Excel sheets and several other examples we have had till today. If we had a dynamic functional master facility registry, we'd be able to tell which facilities are ready for end-to-end digitization and which ones require what. So these are certain things that we anticipate the counties to pick up. So when you hear 1st October, this is what we should be thinking about. And even as the presentation was being done, I kept on wondering, even as we go and focus on the HIV program, whether we are seeing that Kenyan who's attending the HIV program, perhaps starting even from outpatient. That's a person who may be identified at outpatient. Have we thought about that whole workflow so that then finally they open up to the HIV modules, related modules? How does that work? And then for where we have several EMRs in a facility, or for example, where we have KenyaEMR as the HIV EMR, but then that particular facility may be the rest of the facility has Afya KE or has Tibabu. Are those two integrated? Those kind of questions is what we need to keep on asking ourselves. Otherwise, that's all for me. And thank you once again. And of course, Dr. Manya, the head of directorate, if he's here, I don't know whether he had spoken, but for sure he's tuko pamoja on this. Thank you.
Yeah, thanks, Daktari. Very loud and clear, especially on how the country is moving. Looking at a patient more holistically than disease based. So I think in the interest of time, we want to proceed now to look at the demo. But I also want to recognize that Dr. Jacob is in the call. He was able to join us. I know we had a lot of challenges at the beginning, a lot of being knocked out of the meeting from the limit, and then also trying to join on this other side of YouTube. But here we are. So Dr. Jacob, I think because I can see we are getting some attrition here and there, I want to give you just half a second to say one or two things there has been, I think before you joined, I'm not very sure at what point you joined, but I was just mentioning that there's quite some good comments in the comment section in the chats around the enhancements. But there has also been some challenges and issues that have been highlighted. I think just to mention quite a few. One was the speed based on the capacity of this, the gadgets, the machines that are currently being used. And I think the issue around the system being heavy, and so it's a bit slow on the systems. Two was that the healthcare workers would have wanted to also be able to be supported for physical meetings. I want to believe the physical meetings here mean, like on-job trainings. And I do know that we have plans to have the implementing partners support the healthcare workers while they're in the facilities to be able to interact with the system better. I think with those two, those are the two that I picked, but I would also just want to ask you for 1 or 2 minutes to say something, and then we can proceed to the demos. Dr. Jacob?
Yeah, thanks, Dr. Lily. If you can hear me, just confirm.
Very well, yeah, very well. Please proceed.
Yeah, so I think for me, a few issues that you have said, and thank you so much for giving me this chance. For trainings, we normally collaborate with service delivery partners who are based in the counties, and I know they have done a very good job to sensitize partners on KenyaEMR before, and I know that they are up to the task to get partners to be involved. This may involve maybe county-based sensitizations, but also mostly on-job kind of engagements. We've gotten feedback on KenyaEMR being slow in some instances. Many times it has to do with how the system processor and storage is configured in the facilities. And when these ones have been provided in adequate quantities on the existing infrastructure, the system has actually responded very well. So we encourage anyone who is experiencing this, just reach out to our service desk. They'll be able to support you. Both Palladium and Health IT team are available to support with these activities. We never start with a perfect system, but we have done our best to make sure that some of the issues we faced with 2.x have been addressed, so that what we are dealing with probably will be much fewer issues with the system than we have done in the past. I know some of you may be having older versions of 3.x in your site that have some few issues here and there. The version that we are sending out on the 16th will have many of these issues fixed, and you should be able to have a better seamless experience. I think, Lily, I'll probably give a bit more comments at the end. So for now, I don't want to take up a lot of the time that are set for the demonstrations and views. And definitely, we will have follow-up virtual sessions where the team members can interact with specific modules. Over.
Yeah, thanks, Doc, also for your assurance on the support to be able to interact with the system. And so at this point in time, allow me to now ask Eric to take us through the demo. As Eric is coming on board, I just want to seek your indulgence to extend for another no more than 15 minutes into this session. As you recall that we had some challenges as we were beginning. So we lost quite a bit of minutes here and there. Allow us to extend for no more than 15 minutes to be able to see how the system is operating. So Eric, kindly, if you can stick to no more than 10 or so minutes, so that then we can use the last 5 minutes to wrap up. Thank you.
Thank you, Dr. Lily. I was just waiting for the mic. Allow me to share my screen. Confirm that you can be able to see my screen.
Yes, Eric, we can see very well. Thanks.
Thank you. I'll showcase what Kezia talked about, but now this time around, I'll be doing it within the KenyaEMR. What you can be able to see right now, this will be the new login page for the KenyaEMR. Now that you're moving from 2.x to 3.x, so you'll be given the login credentials. And something to notice is that now we are going to implement a role-based system whereby depending on your login credentials, we'll only be able to see depending on the work that you do within the facility. So I'll not take a lot of time, just only to showcase what has been changed as per the revised tools. And to start with the HTS, allow me to pick one of my clients here. This will be the new patient or the client homepage. And when you navigate on your right hand side, whereby you can be able to see the clinical forms, when you click on these, you'll be able to see all the forms that this particular client is eligible or you can be able to use to record any information. To start with the first form that I'll just showcase, it's on the HTS eligibility screening, and this is how you'll be able to open that form, and then you can be able to record. This is the part, the population type that Kezia talked about, whereby now you'll be having the general population, and then key and vulnerable population. And when you click on the key and vulnerable population, then you'll be able to see all the typologies there for the both. So you can be able to see, and even now Fisher for coming in as one of the vulnerable population. So this is one of the area that has been changed for this form. And because of time, just allow me to highlight as per the revised tools. When again, navigate back to the HTS initial form, to the HTS recordings, this is the first part that I've talked about. So this cuts across all the forms that needed to document the population type. And then the other part that has been affected or changed, it's on the test kits that we are going to use when we are carrying out the test. So this has been validated to incorporate the 3-tier testing and again, the testing that we have within the facility right now. So when you look at the HIV test 1, we will not be having the screen being introduced. And again, determine that was there. Kezia explained the reason as to where we'll be having the 2 for the time being, and I don't want to repeat on that. But just to showcase how the 3-tier testing will be working. So if I say I'll be using the screen or the HIV test 1, then I'll be able to record the lot number, the expiry date, then I'll be able to give HIV test 1 results. So if it's negative, then my final results will be negative. But if it's positive, again, I'll be required to do HIV test 2. I'll be able to select the kit that I'll be using. So for this, let me use 1 step, then give the lot number, the expiry date, then I give now the result for the HIV test 2. Again, if it's negative, then I'll be required to carry out the third test as per the new algorithm. And then if it's positive, again, I'll be redirected to carry out the same the third test. And then once I give the results, then the system will be able to give me the final results. So this is another section that has been enhanced. Moving now to care and treatment, and allow me to change a client. Majorly on the Rose, when Rose was projecting, talked about the clinical encounters, which will be majorly used to document any service that has been offered to the clients. So again, this is how we'll be able to access the HIV green card. And the part that has been again affected, it's on the same on the population type. And again, as I have talked about in the other forms. Then moving to the next part, which is adding on the patient management under the PHDP services. You'll notice that under the screen for cervical cancer, if the answer is positive, then this variable whereby you want to know whether the client was treated was added. Then the other part which was added, it's on the establishment, whereby we've added the differentiated care model, whereby we require first to say, is it a facility ART distribution group or the community ART distribution group? And depending on what you select, if it's facility, then you'll be able to see those models appearing. Is it PICA HFAG, or is it fast track or standard care for that facility ART distribution group. That has been done for the community and facility ART. So it has been validated, whereby you'll be able to see more options for the community, even community pharmacy being part of that. Then harmonization of the appointments, whereby we used to give our appointment within a form, but right now you need to click on the add appointment. Then you can be able to create new appointment, whereby you need to select the service. So the location and the date of appointment issued will be auto-populated for you. But for the service, you need to select if it's HIV consultation that I'll be coming for, then I can be able to choose which will be scheduled. Then if when we use this, it's if it occurs each and every day. But because we know we only give a specific day, we just let it be no, and then move to the date. And this is where you can be able to specify the date. So for example, if it's after 2 weeks, which is 26, then this calendar will appear, highlighting this date 26 with a different color. And then there is a number that you'll be able to see here. So this means for that particular service that you want to create appointment, on this particular 26th day of August as 0 booked clients. So this will be the first client. And the reason as we have this calendar, it is to help our clinicians to evenly distribute the clinics and manage their clinics. Then if, let's say we are booking for a specific particular time that you would like to attend to this client, then you can be able to specify the time and the duration that this service will take when 26th of August comes. But if you don't give specific time and duration, then you can turn this all day to be on, meaning that we've booked you to come on 26th August, not giving you specific time that will take when you get to the facility. Then moving to the other thing that was has been revised as per the key and treatment. It's on the PHQ9, and this is whereby right now you'll be able to see only the first 2 questions. Depending on how you'll be able to respond to these, the system will be able to give other follow-up questions. So for example, if I say, let's say for the little interest, that's little interest or pleasure in doing things, it's several days, then you'll be able to see other questions coming up. And upon responding to all these questions, then you'll be able to see the depression score appearing. Depending if what you'll be able to see again, then we've added the psychological first aid, that is the PFA. If offered, then you'll be able to see other questions if referral was done and facility where you referred. So if it's other facility, then you can be able to search the name of that facility, and at least you'll be able to type the name of the facility and give the service that you refund for. Was it psychiatric service or psychotherapy service? The other thing, it's on the triage. Right now, you'll be able to record triage from the patient homepage. You just click on the record vitals, then you can be able to take your vitals as listed. We have all those, and depending on what you'll be able to key in, then we have the inform alerts that can be able to let you know if it is out of the normal range. Then the other thing is, depending on the weight and the height, which is mandatory, then you give, let's say, that. Depending on the nutritional status, then the nutritional interventions has been added, and you can be able to see them there. If the nutrition counseling for a normal case, or maybe the supplementary feeding program, it's needed. So this is something that, again, that has been added. Moving to a different program, that is MCH, and allow me to change again my client. So number one, how will you be able to know that this particular client is enrolled in a certain program? On your left navigation panel, you'll be able to see care panel. And when you click on the care panel, then you'll be able to see a panel summary that will be able to show you all the programs where a client is enrolled. And if you want to enroll, again, you can click on the program enrollment, and then you'll be able to see all those programs where one is eligible to be enrolled into. Focusing on what Kezia talked about on the revision as per the MCH, allow me to start with the first one, which is the antenatal visits. And number one, when you look at the way now the MCH antenatal visit form is, it has been broken down into 4 areas. We'll be starting with the visit details. We record the patient history, and then we get to the patient examination, where we can be able to examine the body. So number one, it's about the testing. This has been changed to incorporate the 3-tier testing again, as I demonstrated using the HTS forms. Then what I've not talked about here, it's on the preventive services. This has been now been incorporated. In 2.x, we used to have them as 2 separate forms, but now within the antenatal visit, you'll be able to see the preventive services there. Then something that the breast examination done. So this has been enhanced so that you can be able to record whether was it normal or abnormal. Moving to the next form. That is the delivery form. Again, when you get to the part where we record the history at the tail end. Sorry, not the history. So number one is the same as the same format. The reason as we have the 4 areas, we want to make it more clinical, to adopt the clinical workflow of recording the patient history, the examination, and then we finalize with management. So just want to locate the question that was enhanced here. That is on the birth. So under the birth with deformity, if you say yes, again, this type of birth deformity, the congenital syphilis, spinal bifida, hydrocephalus, and then the tallips, it's another section that we managed, was revised and incorporated within this system. And then the baby mother pairing can be done while recording the delivery form once the baby has been born. So moving to the other form, which is the postnatal, again, the same clinical workflow will be followed, whereby you'll be able to record the history, examination, and then the management. The 3-tier testing was incorporated, but starting with the postpartum visit, timing mother, and the one for the baby, can be able to say this was revised to 0 to 48 hours, 3 days to 6 weeks, more than 6 weeks. And that is both for the mother and also for the baby. Then when you get to the examination part, also the issue of fistula screening was again, this part was revised, and you can be able to see the addition of viscovaginal reflux being added. Moving to now the baby. On the CWC discontinuation that we talked about, the option of the moving the 24, when we can be able to discharge hay, we've added another option, not to be 18, but now to be 24. Allow me to move to the last program, and that is the key and vulnerable population. And the first form, that was the contact. So when we want to enroll one into the KVP program, the contact form is used. And when you get this, and then you click on you just highlight the program name, and then you click on the enroll, you'll be able to see now the KVP contact form and some of the changes that have been implemented, that is under the population type. So right now, you'll only be able to see less questions, but they have been validated depending with on the typology that you take. So if, for example, I take the Fisher folk that I know as one of the vulnerable population type that has been added, the questions that will follow up here depends on that typology. And this is maybe where do you mostly operate, you'll be able to see that. And then the type of operating site, that may it be beach or the landing site, this one has been added, and then can be able to specify which type of fish business do you primarily conduct. And this is a multi-select, then the name of your beach or the landing site, and which year did you start fishing. So this is another form that has been revised. So depending on the typology that you take, if it's a truck driver, again, these questions that you'll be able to see here depends on the typology. The type of hotspots, now you'll be able to see so many of them, and you can be able to select the most appropriate one. Which year did you start tracking? So the questions that you'll be able to see here, and these are the questions that Kezia took us through, depends on the typology that you'll be able to see to choose within the key and vulnerable population. The other thing that I want to talk about on the KVP programming, it's another major form that we used to call it clinic visit form. We are now switching to calling that form the KVP clinical encounter. And some of the services, allow me to just go through this form very fast because a lot was changed on the services that you can be able to offer. So you'll be able to reckon the HIV test results, whether that was offered. If not offered, then you select not done. But whereby, let's say, the same information was recorded within the KenyaEMR, we'll be able to auto-populate that. Then the STI screening, whether it's yes or no, and if it's yes, then the STI results, you'll be able to document. The risk reduction counseling, education and promotion offered, whereby it's a multi-select. If I select, for example, condom, then I can be able to specify the number that was given. Then for the TB screening, hepatitis B antigen test, whereby if I say it's yes, then what was the results? If positive, then was confirmatory test done. And if it was done, what was the results? Then again, hepatitis C antibody test done, behaving the same as hepatitis B antigen tests. For the PrEP, whether the client was screened, and if eligible, was the client initiated, or is the client continuing on the PrEP status? Then the type of PEP type of exposure, the annual cancer screening, was it done? And if it's yes, what was the results after screening? The HPV vaccination status, the cervical cancer screening, the HPV vaccination status, violence screening, on family planning, mental health screen, overdose management diagnosis results, then the offsite ART status if the client receives ART in a different facility or DICE than the one that is offering the KVP services. And again, the harmonization of how we are giving the appointment, as I described while showcasing the care and treatment. So this is one of the form that anything that was related to care and treatment, as Kezia indicated, was dropped so that you can be able to make use of the care and treatment module. The other forms that you'll be able to see, but those forms appear depending on the type of the client that you are working on. That is on the opioid overdose report, overdose form that you can be able to see on that. Allow me to move on. How can we be able to access reports within the KenyaEMR? So while at the KenyaEMR homepage, the supposed to navigate to the top of your right-hand side where we have the KenyaEMR modules, then navigate and locate KenyaEMR home. When you click on that, it takes you to the older user interface for now, and then click on the reports. So the way we used to generate the reports is just the same way we'll be generating our reports. You'll be able to see under the common, the MH731, and if you can be able to see this, my screen, this is what you'll be able to see. And generator one can be able to see some of the indicators within EMTCT being populated there, and even some of the reports on the HIV testing. And I know you'll be notice that for HIV testing services now, which was section 1 in MH7.1 was merged to report on HIV testing services and pre-exposure prophylaxis. So PrEP report, you'll be able to see it under that particular section. Moving to these other reports, when you get to the MCH Mother Services, you'll be able to see all these registers, and they have been revised as per the current registers that will be rolled out by NASCO. Again, when you move to MCH Child Services, you'll be able to see the HEY register, MO710, all these reports have been revised, and you can be able to generate them. Then the key population here coming in now with a separate MO7, that one for VP and that one for the key population. And the rest of the registers, again, they have been revised, and you can be able to get them from here. Back to you, Dr. Ridley, for that. I hope I've not used more than the expected time. Dr. Ridley, back.
Yeah, thank you so much, Eric. Very clear demonstration of the updates. And I know I keep saying the more we interact with this system, I think the more we'll get to appreciate some of these changes, especially in light of the changes also in the clinical management, because that is what has guided or driven this change. So I see we have one last presentation, but I also want to appreciate that we are seeing quite some attrition. I see around 50 people have dropped off so far. So I'm going to give 5 minutes to Nishauri up. Otieno, kindly, if you can just take no more than 5 minutes so that we can work towards wrapping up. To the audience, kindly allow us 5 minutes. We get to also see one of the apps that is also going to be a game changer in how we are going to be interacting with our patients and our clients. Thank you.
Thank you, Dr. Please confirm if my screen is visible from your end.
Yes, please proceed. Thanks.
Thanks. Yeah, so as we wrap up, I think we just wanted to mention that there is this application that is also very, very crucial, which is basically a patient-facing application that our patients can download and use to monitor their own health. So it has got a lot of functionalities that I'm going to just go through very fast because of time. So one of the key functionalities of this particular application is about a patient appointment management. A patient is able to view their upcoming appointment, look at the previous appointment, even request to reschedule the appointment should they be engaged or something like that. They can post that through the application, and that will be updated on the other side, on the EMR side at their facility. So that is a very important utility. There's the feature for very personalized health, like for instance, the yellow card that our patients sometimes have. So there is an e-clinic card in this particular application. So they don't really need to carry their yellow card with them. All that information is contained within this particular application. Again, also access to their viral load results. They can access this in real time. As soon as the results are back, they're able to see this on their phone. And also they can monitor how they have been progressing, how they have been doing in terms of their viral load status over time with very nice graphs. And they're able to really take charge of their own health in terms of trying to manage their viral load. That also goes with the comprehensive profile that has been expanded to include all the information about the patient, personal contact, health, physical, and lifestyle information that have been updated on that as well. Again, also screening, self-screening features are also available right now in this particular application. Patients are able to record their BMI, they can check their BMI, they can also record their blood pressure and look at that over time, as well as recording their blood sugar. If they have this equipment where they're able to self-test and then they record in their application, over time they'll be able to monitor how their graph is doing in terms of either blood pressure or blood sugar, as well as the BMI. And that can also be tracked historically. Then there is one interesting application, the chat application called Nuru in the application, where they can just interact and ask any question. Nuru will answer, and Nuru can now answer in both English as well as in Swahili. So it's very, very interactive, and patients are encouraged to really try it out. Again, more functionalities. There is expanded facility directory where now patients are able to just check if at all they are anywhere they want to check if there is any CC a facility around. They can just check through the app. They'll be able to get this the CCC contact, the MFL code for the facility. They can contact that facility should they want to drop in maybe to pick their drugs. That is available. Security has been improved in the application, so there are no worries that a third party can access individual information, where now the patient can even lock the application with their biometrics as well. So that is very key. And last but not least, the last interesting feature on this app is the DAWA drop, where the stable patients can now just at the comfort of their homes order and request drug delivery to their doorstep, just like Glovo and Jumia Foods. They can request this, and these drugs will be delivered to their location. So that is also a very key feature. And this helps them to even track open deliveries. They're able to tell where mtu wa bike amefika. They'll be able to also look at the history on how they have been delivering. They've been requesting and receiving deliveries for their particular drugs. So in terms of rollout of this particular application, we have quite a number of patients that have already started using this application, over 26,000. But we still ask the counties and the partners to keep on sensitizing the patients to ensure that they're able to install this, especially the clients who have smartphones. They're able to install this so that they can now start taking charge of their healthcare. Also, to ensure that we reach out to many patients, we'll be leveraging our Ushauri SMS application just to notify all the clients that are in care on the availability of this particular application, and with the instruction on how to install on their smartphones. So the statistics in terms of the number that are currently using the application are shown. Is the uptake is really very low at 2%. That is very, very low. But I think with constant sensitization, we are sure that we're going to have more patients using this. Then I'll just go rush over this because of time. It's important to understand our release management. We are going to have a release this Friday on 16th, as Dr. Wamushi has just, Dr. Lily has just said. But this will be hosted on our GitHub page. So all the partners, all the facilities, all the counties that will be looking towards getting this particular application will be able to get it on GitHub, and we'll keep on monitoring to just see how the uptake is, and if there are any challenges, we'll be able to take that and also go through the same life cycle to ensure that we incorporate all the feedback, and then we make the system more stable as we move forward. Last but not least, as already been alluded to by Dr. Jacob when he made his opening remarks, we are planning a series of virtual trainings that we are going to carry out every Thursday from 2 to 4. And these virtual trainings will focus mainly on all the aspects of the system, not only the HIV. We'll be having non-HIV sessions as well, which includes all the new nice features on the KenyaEMR 3.x, plus the OPD, the billing, and all the modules that are on KenyaEMR facility-wide version. So we really strongly advise all the partners and the users and all the counties to purpose to join these virtual sessions every Thursday from next week Thursday from 2 to 4. So we'll be sending out a communication on this to all the stakeholders so that you can join these very important trainings. Otherwise, should you want to reach us for any technical support, we have service desk contact that's already posted on the chat, but we have a toll-free line that you can always call or email us on the email that is on your screen. Otherwise, thanks, and I would like to take it back to you, Dr.
Thanks, Bernard, and really appreciate for taking the shortest time to take us through that last part. As Bernard has highlighted, we start now to have more in-depth modular sessions, and I believe in those sessions we're going to be able to get better understanding of the different upgrades that have been made. So at this point in time, I just want to allow two people to make their remarks as we close. I shall not belabor my call to action. We proceed to start doing our upgrades. We take note of the different virtual trainings that have been scheduled as is put on the, please leave the, as has been projected up on the screen, so that then you can be able to have a better interaction with the system once you upgrade that. And then, of course, we shall be meeting you at some point as we roll out, as we, fully transition to the use of the new tools. So I've also seen quite some chats. Of course, I think a huge applaud to the Dawa Drop and the Nishauri system, which are really aligned to patient empowerment, which is, I think, really the way to go for as we proceed to provide services that are patient centric, so that we allow the patients to be really at the control of their care. So I just want to request Dr. Jacob. I know he had indicated that he would say one or two things towards the end. So Dr. Jacob, maybe one or two things, and then we hand over to Dr. Wamishwe. And I don't think Dr. Amanya was able to join us, but we can have Dr. Wamishwe say one last statement, and then we shall end the meeting at that point, and we shall then be seeing you in the virtual meetings that are scheduled. Dr. Jacob?
Yeah, thanks, Lily. And I think what I can just emphasize are maybe 3 or 4 things. So the first one, KenyaEMR 3.x has more features than what you used to experience in 2.x. So there's real value in joining. Some of the things that are upcoming because of the integration with the Ministry of Health Client Registry is that there may be a transition sometime during the year. If you really want to benefit from shareable health records at robust referral, you want to benefit from unique personal identification in a robust way, you really need to transition to 3.x. And maybe Joyce, you can just talk briefly about maybe some support that the MOH may provide to partners who are going facility-wide, because that has been an issue that partners are talking about. The transition to 3.x will also be monitored. We'll be sharing regular updates on the progress of transition to 3.x through NASCOP. So hopefully that will give you feedback on the progress we are making on upgrades, so that then you can be able to track your own performance as a partner and a county heading towards this. Finally, is that when you upgrade your facilities, HIV clinic to 3.0, you have actually contributed to the facility-wide deployment, because now what will happen, the site will just be configured for facility-wide when the time comes and when the infrastructure has been bought, so that then you can be able to activate the other departments as needed. So we really encourage you to take this up, attend the follow-up webinars, so that then we can be able to walk the journey together with the ministry as it revolutionizes how digitization of the health sector is managed. Thank you, and over to you, back to you, Lily.
Dr. Wamishwe? Okay, in the absence of Dr. Wamishwe, Dr. Wamishwe? She's still can't unmute.
Okay, now I can't unmute from my side, so I need you guys to keep on unmuting me. But anyway, regarding the facility-wide digitization, I mentioned we are planning for a readiness assessment to basically go through the entire, assessing a facility. What does it require? Number of sockets? Do they have a data protection officer somewhere nearby? An IT champion? Those kind of things that we usually do when we're deploying for HIV program, but now we are doing it for the entire facility. The government will support through its partner. There is a service provider that's been brought on board for end user devices. What I don't know is whether it is going to be all end user devices, but that's why we need the assessment. and then training. And then specifically for KenyaEMR, we are also praying and hoping that Palladium and the IPs can also assist in certain things like training of healthcare workers and supporting them even thereafter. Given that we know what it takes to deploy, we know that even that 1 week training or 2 weeks training is not enough. The support is particularly very important. And when I presented earlier, that is what I meant by onboarding, ensuring that a facility is comfortable to provide healthcare services using IT. The patient portal is very good. My question is, okay, so a typical patient would have the normal patient portal, that's Afya Yangu, and then would have this other one. It's okay. I mean, people have many apps on their phones, but it would be nice to think about it, even going forward, what that would mean to a patient, because again, we don't want to stigmatize some of these apps. So even as we are coming up with an app for HIV care, can we try and begin to sell it or market it as maybe a chronic care disease app, so that HIV is just one of the things that we are following up on. It's a point to think through, but so far so good. Lily, with your permission, it would have been really interesting to hear what a county representative thinks about all this, and perhaps an IP. Thank you.
Yeah, thanks, Daktari. I think we had, and thanks for your remarks. I know we had indicated that we had the implementing partners on the ground, the CHROs and the CASCOs, and of course the healthcare workers. At this point in time, I'm feeling, because of the attrition, and also we are 2.5 hours into the time, we may not need to go to that direction. We have seen quite some chats. I just want to ask Diana, so if you can hear me, have you been able to pick anything that needs to be addressed really quickly before or any comment that we need to take note of? I'm seeing a lot of questions around the physical meeting. As you have noted in this meeting, we also had quite some challenges with the technology. We shall also be requesting for some physical meeting to build on some capacity around how to do virtual meetings. Of course, all pun intended. Diana, did you take note of anything that we need to highlight in this meeting? Alternatively, I'll probably ask one of the healthcare workers to just unmute, share their reflections really quickly. We have 2 minutes to end this call. Anyone who wants to share their reflections based on the discussions today? Am I supposed to unmute everyone? Okay. Let me just unmute. Just lift your hand. I can be able to see you, and then I will unmute you.
I have allowed the participants to unmute themselves so they can.
Okay. We don't seem to be having, let me just look. Anyone?
We have Anna Omondi.
Omondi? Okay. So last call. All right. Then I don't think we seem to be having anybody who has any reflections. I believe we allow people to synthesize the information that has been shared, to start, touching the system, and familiarizing themselves, and I want to believe that the next forum will be more interactive. So at this point in time, allow me to really appreciate all of you for staying on, even despite the challenges. We do hope to try to shorten another meeting like this, but sort of like repeating it, especially for the people who may have given up after the first few minutes of the technology hitches, and then we shall keep interacting with you. We are also planning as a program, because we do have other meetings that require us to visit you at facility level to see how we can integrate and be able to support you at any one point in time when we are able to interact at facility level. So with that, asanteni sana, and we'll continue to interact in the different forums that we exist in. Thank you and have a good evening.